So a big hello to Dr Andrew Klein, Cardiothoracic Anaesthetist from the Papworth in Cambridge and Editor-in-Chief of the Anaesthesia Journal. Thank you so much for coming.
No problem.
I really enjoyed your talk. It's a very confronting and thought-provoking topic. And I know we can't extrapolate your results to non-cardiac surgery, but I have to say it's very reassuring to know that mortality outcomes were not affected by individual anaesthetists in your study. There's sort of a feeling of being let off the hook for now. I do worry though about the effect that publishing this data to the public will have on our surgical colleagues who already work in high-stress, high-pressure competitive environments. And I know that patient safety is paramount, but I also worry about the safety of our workforce. And do you have any thoughts on how this has affected the mental health of our surgical colleagues?
Oh, I have no doubt it's been very stressful for them. Yes. I mean, the data has been published in the public domain for more than 10 years now. And it's reviewed regularly. It's published as a continuous audit by the National Health Service, and it's available on the internet, as you said. And there's no doubt it is stressful for them, but patient safety is the number one concern. And I think there have been scandals in the past where a group of patients have died in individual institutions, which I didn't go into in my talk. But when that sort of scandal happens, it places a focus on the whole team. Yes. And if there's something going wrong in the team for whatever reason, that needs to be discovered and managed in an appropriate way, but the patient has to come first. And I think the patient is at the centre of it all.
Yes, absolutely. And your talk also demonstrated once again that using incorrect statistical analysis can have enormous effects, and that it is very, very hard to retract data once it's been put out there. And I just wonder, as a highly trained profession, we still sometimes get this wrong. And I wonder how we can expect the public to critically appraise the kind of data that they're presented with.
And that is a major problem. I mean, we find it hard to critically appraise it, let alone the public. You need high intensity, high quality statistics to analyse it, and that is the problem. Yes. That whatever data you put out there is out there. And that's one of the disadvantages of the system, and that's why I'm not advocating that we put individual results out for an anaesthetist in the public domain, as you heard in my talk. But when it is so critical for patient safety and patients are dying, it is important that we look if publishing the data can actually help patients. And there is evidence, as you heard, that publishing the data and changing practices can actually improve patient safety. So although all the difficulties are there, when there is good evidence for it and it's been looked at, well, then I think we just have to do it.
Yes. Okay. And also one of your main take-home messages was that 96% of risk is from the patient themselves and their comorbidities. And I feel that there's sort of a bit of a trend recently to stop blaming patients for their comorbidities. And it's true that it's not necessarily under their control, but similarly, often it's not under our control, or they're not things that we can modify ourselves. But we are expected to just sort of be able to manage more complex, more unwell, more comorbid patients while still improving our outcomes, our safety outcomes, our morbidity and mortality. I wonder whether we're just kind of setting up unrealistic expectations for the public.
I think that's very true. People expect to survive major surgery, whatever.
Yes.
And we have shown that high-risk patients undergoing major surgery don't necessarily do very well. And we have to accept that, and we have to tell our patients that that's the case. So we need to inform them that, that they are at high risk, that they can't do anything. We're not blaming them for their comorbidities, but that they are what they are. The patient is the one with the disease, as I said in my talk, and that they have to accept that there is a higher risk, and the unreasonable expectations that they may have had need to be changed by using the things like the Euroscore that we talked about and telling them what their risks are.
Right.
And for us, it is difficult to manage these complex patients. And when the patient has such an influence on their own outcomes, as I said, 96%, as you said, it's about optimizing the patient. And there are a few things we can change. We know smoking cessation improves outcomes. We know that exercise prehabilitation, getting patients to exercise within their limitations, improves outcomes. We know that better dietary improve outcomes. We can influence their hemoglobin by treating their anemia, and that's a big focus of research. So I think what we need to be looking at is how we can optimize our patients in our patients' best interest, not blaming them for their their weights or their hemoglobin or whatever, but just making them better to improve outcomes for them.
So it's like giving them the information and then getting some buy-in from the patient to try and improve.
And I think someone said before me in the talk, it's not all about rushing into surgery immediately. You have a diagnosis, you do an operation. That's very tempting. You have coronary artery disease, you need cardiac surgery. Sometimes it's better just to wait, say, okay, you have coronary artery disease, we're going to make you as best as we can before we operate. We're going to optimize your hemoglobin, get you a bit fitter, give up the cigarettes, get you eating and drinking properly, and get you as healthy as we can before your surgery. So sometimes it's not about rushing into operations, it's about helping our patients with education and with managing any comorbidities before we operate on them.
Excellent. Also, just as a side note, I understand that you're involved in the great anesthesiology debate tomorrow, and I wonder if you can just give us a bit of a sneak peek on how you think it might go.
Well, I think it's going to be close. It's going to be a very interesting debate. It's a highly emotive subject. It's caused lots of debates already in the bars and cafes of Sydney. But I think, is it a name that's important, or is it our behaviour, the way we behave as doctors, as physicians? So I think that's going to be the focus of the debate. It's not in the name, it's really our behaviour, our attitudes, and how we look after our patients.
Sure. Excellent. Thank you so much.
Okay, no problem.
It.
Nice to meet you. Cheers.